Welcome, everyone. I'm Amanda Egan, the Director of Patient Engagement and Clinical Programs with the RUNX1 Research Program. I'm here to kick off the webinar Introduction to the RUNX1 FPD Sirolimus Pilot Study. And we're really happy to announce that the second clinical intervention trial for RUNX1 FPD has launched, and that today we have the PI of the study here to speak about the trial, its rationale, who's eligible, and what a patient can expect when participating. So presenting today, again, is Dr. Courtney DiNardo of MD Anderson Cancer Center in Houston, Texas. She's the principal investigator for the study. As you likely know, Dr. DiNardo specializes in personalized treatments for AML patients, leading many clinical therapeutic trials like this. She's also a longtime advisor to RRP and is part of our scientific advisory board. We also today have with us the co-investigator for the study, Dr. Anupriya Agarwal. She's professor of medicine at OHSU in Portland, and she's also a longtime friend of the RRP, a funded investigator that we've worked with for a really long time. Her research focuses on identifying the causes of blood cancer initiation, cancer growth, and how some blood cancers are resistant to treatment. Her goal is to take her research learnings and use them to discover newer, better treatments for blood cancer patients and to discover blood cancer prevention treatments. So her research is the reason this clinical study was developed. And so she is here today to speak to any questions you have on the research in the lab that indicated sirolimus should be tested in RUNX1 patients. So please note that Dr. DiNardo prepared her presentation specifically for a patient audience. We know that some clinicians and scientists have registered to be with us today, and we're really glad you're here. We'll do our best to answer all questions that you have, but of course we will prioritize patient questions first. So let me just cover a quick housekeeping item. In case you're unfamiliar with the webinar format, there will be a little Q&A icon you can use at the bottom. So feel free to open that up and ask your questions during the presentation. If you type them in, you'll have an option to actually select to ask the question anonymously. So that's an option to you. But regardless, I will read the questions out at the end to Dr. DiNardo and Dr. Agarwal, and I will not mention your name. So this is a confidential format to ask those questions. Let's see, what else did I want to share with you? So ask any questions you have. This should be a really comfortable format for that. And please recognize that presentation contents and responses to questions should not be considered personalized medical advice, of course. And so with that, I will stop sharing and let Dr. DiNardo take it away.
Sure. Well, thank you all for being here. And so we'll kind of highlight what this underlying study is, which is a study of sirolimus for patients or individuals who have RUNX1 FPD, RUNX1 familial platelet disorder, which is associated with elevated levels of inflammation in the bone marrow, with, in particular, elevation of a pathway called mTOR1 is something that has been investigated pretty carefully in Anupriya's lab, and she can go into more detail if needed based on questions. But just kind of this is important for RUNX1 FPD specifically, as well as cancers in general, where we see chronic elevated levels of inflammation associated with many different types of cancer development. And so there is certainly a theory, which has actually been proven in certain areas, that lowering mTOR1 can reduce the production of inflammatory proteins, and hopefully thus preventing the development of blood cancers in this case. So a little bit more of a background in kind of a visual format, where these higher levels, these inflammatory proteins, which are highlighted by these kind of yellow triangles, are there. And with time, as you have this kind of chronic level of heightened inflammation, we can see these precancerous kind of early stem cells develop, which can kind of increase, and as time goes on, over many, many years, and second insults and hits lead to the development of a blood cancer, which is highlighted by these red circles in this diagram. So, and certainly many of you, I think, are aware, most people with RUNX1 FPD will not go on to develop a blood cancer, but some people will. And so the question, of course, is what can we do? How can we help prevent this from happening? Is there any sort of early prevention approach that could be safe and well tolerated and also effective? That's, of course, the number one goal. And so, why sirolimus? Why are we doing this? Well, we know that, just as kind of secondary information, that patients who have germline RUNX1 mutations have a high prevalence of certain kind of inflammatory conditions, right? Eczema, allergic conditions, autoimmune diseases, just kind of further enforcing the background that we see this kind of this aberrant inflammatory profile. And the data that I mentioned already, that we have this hyperactivation of inflammatory signaling and altered immunity, which includes and is associated with this upregulation of mTOR. And so can we suppress this abnormal activation of mTOR? And so there are mTOR inhibitors. So sirolimus is one of them, but there are many others. You may have heard of everolimus or temsirolimus. There's a whole class of mTOR inhibitors, which are approved for various different things, including certain cancers, which can reverse the abnormal inflammatory phenotype. And it works in lab experiments. Sirolimus is safe and effective. It's used and FDA approved at high doses to prevent rejection of organ transplants. So in particular, kidney transplants and liver transplants, some lung transplants, patients will get sirolimus. And there's actually been some studies, which I hadn't actually been aware of all this literature before I started kind of researching and working on this protocol. But low-dose sirolimus for 6 months has been safe and effective in several studies of different healthy patient populations, including one that is for patients who are at a high risk of developing colon cancer due to familial predisposition genes to colon cancer, where it was associated with less polyps, smaller size of polyps, and confirming that there was a decrease in that abnormal mTOR signaling in patients with that colon cancer predisposition called FAP, familial adenomatous polyposis. And so this is, the most data-heavy slide I have, just going through a little bit more of the data. The point of this is not that you look at every single time point on this timeline, but just to highlight that this drug has been around for a long time. And it has gone through an evaluation of phase 1, phase 2, phase 3 clinical trials, and it's approved for certain indications. And it really is, it's something called a protein kinase that controls cellular metabolism, immune response, survival, various different kind of important cellular homeostasis genes. So it's kind of just what it means is kind of keeping things in balance, right? And so when you have this upregulation of mTOR, things are a little bit off balance with this heightened hyperinflammatory signature. And so it's generally considered to be an immunosuppressant, but actually, immunosuppressants can lead to cancer formation. And this is actually not really an immunosuppressant. I think the term immunomodulator might be more appropriate because it has both, effects on the immune system, but also seems to decrease cancer incidence in several studies, including that cancer polyp study that I was just highlighting. So, so what is the idea here? And just, highlighting again with this figure, so we've got these yellow triangles, which are that kind of hyper-inflammatory proteins that are being circulated in the average individual with a germline RUNX1 mutation. And so instead of that normal pathway that we just went through, the hope is by adding a daily oral therapy of sirolimus, we can kind of delay or prevent or somehow overall improve upon the overall health of the blood system and the immune system of a particular patient on trial. And so that leads to the pilot study, which is exactly as it says, sirolimus to decrease inflammation and maybe even improve blood counts in individuals with RUNX1 FPD. So what's a pilot study? Why is this a pilot study? So a pilot study is a trial. It is a clinical trial, and it is being done. It's not really a phase 1, phase 2, phase 3, because this drug is already FDA approved, but we're using it in a different fashion, right? We're using it for individuals with RUNX1 FPD. And so we don't have kind of the money or infrastructure or frankly, the knowledge yet to say we should be moving this into a huge evaluation of patients. Let's get a little bit of information, right? So it's this is going to be a 6-patient pilot study to see if this indeed does what we think it does. Is it going to improve inflammation? And we'll be getting these markers to evaluate that both in the bone marrow and in the peripheral blood of participants. So let's make sure. Yeah. So, a pilot study is really helpful to build the evidence that suggests that, hey, this really could work, and we should be kind of really investing in building a larger study to prove this, to make a formal indication, or potentially that this isn't actually effective and we need to keep looking for other therapies. Hopefully the former, though. So questions to consider. This is a slide specifically for those on the call that are affected or know someone who is. Is this something that is of interest to you? What are the potential benefits we talked a little bit about? What are the risks? I'll go through the common adverse events in another slide or two. Logistical factors is something to consider. This is a study that at the present time is only going to be running at MD Anderson, which is in Houston, Texas. And this is different, unfortunately, than the NIH studies that maybe some of you are aware of, where kind of travel and lodging and everything is covered. Unfortunately, because MD Anderson is not kind of a government-funded practice, it goes through insurance. And so that is something to definitely consider. Does your insurance cover treatment here at MD Anderson? And that's something that I can definitely help you with. My information is on the last slide. And if you are interested, we can certainly kind of look into that and see if follow-up and treatment here is something that is possible. So the primary objectives are to determine the safety and the tolerability of oral sirolimus for people with germline RUNX1 mutations who do not have a blood cancer. So this is not appropriate for people who have RUNX1 FPD that actually already have maybe MDS or an acute leukemia, because one of the key secondary objectives is, does this help prevent the development of a blood cancer? So it wouldn't be appropriate if someone was enrolling that already had one. The secondary objectives are evaluating bleeding symptoms, laboratory changes. We're hoping to see improvement, in particular in platelet counts before and after sirolimus. We'll be measuring markers of bone marrow function, of inflammation in both the blood and the bone marrow samples. So there will be a bone marrow evaluation both during the screening period, which is within 30 days of starting the treatment, and then at the end of the study, which is 6 months later. And then we'll be assessing changes in what are called patient-reported outcomes. These are kind of electronic forms that you fill out. One is kind of health-related quality of life. How often are you tired? How often, are you having various different kind of things, activities of daily living, things like that is a questionnaire. And then there's a specific questionnaire for bleeding and thrombocytopenia type events. So, eligibility includes being an adult. You have to be 18 years of age or older, and your platelet count should be 50,000 or greater. No major medical problems like underlying organ function. So heart function, kidney function, liver function has to be fairly close to normal levels. You cannot be pregnant or planning to get pregnant within the kind of 6-month period that you're on this therapy. You do need to have a confirmed pathogenic or likely pathogenic germline RUNX1 variant, willing to provide that bone marrow sample twice at screening and at the end of therapy with monthly lab checks and visits. And there are some medications that do interact with sirolimus. And so it's kind of an extensive list, not too many standard things, but happy to share that or answer any questions if anyone has any specific questions about the medications they're on and whether that would be an issue. In terms of timelines, it's a new study that is open and is enrolling. Feel free to contact me, and there is kind kind of information about, and I can have the research nurse forward you kind of an informed consent document to look through that'll provide a little bit more information also. But essentially, this is an oral daily therapy that you take on your own. We give you a prescription for 1 month, and you take it every day for a month. And then you come back and you get your new supply for a month, and this is for a total of 6 months. So it's fairly simple when it comes to kind of the nuts and bolts of it. It's really all of the correlative labs and evaluations that we'll be doing that's going to be really kind of detail oriented on our end to make sure the samples are going to the right place and we're doing all of the fancy tests that we want to be doing. And then for you and a patient participating, it's just, you know, being there on a monthly basis for 6 months. In terms of common side effects, certainly all drugs cause side effects, that's true. Many patients tolerate this really well. This is a low dose of sirolimus compared to the kind of doses much higher that people use for organ transplantation, but it still can cause primarily GI side effects, so things like constipation or diarrhea or nausea. Certainly there are medications for all of these. If people have these side effects, we should be able to help you manage through them without needing to discontinue. But certainly, you know, we will work through kind of anything that you experience. There is an association with long time use with higher lipids, cholesterol levels, triglycerides. I don't think that's going to be something particularly impactful for this like 6-month period, but something that we can kind of discuss and talk about. Fluid retention has been associated with sirolimus, so whether that's fluid retention in your lungs leading to some shortness of breath or lower extremity swelling. There are also effective therapies for that we could talk about if needed. Headaches, muscle aches, changes in blood counts, which we hope to be in the positive. And there I saw a reported history of blood clots, although that's not something I think is going to be a major concern, but certainly something that we will be watching for and being cautious about. And I believe that is, yes, so that is my last slide. This is a picture of MD Anderson with kind of all the different collaborators on the left at MD Anderson that I work with, and on the right, people, I'm forgetting many people, but many of the different institutions that I've worked closely with. And I will kind of cut it here and end the slideshow, and then we can open it up to a Q&A session. And let's, as you know, as was said, let's try to start with maybe patients asking patient-specific questions, and then we can move to the more kind of basic science type questions if we have a bunch.
Thank you, Dr. DiNardo. Great presentation. And thank you, Dr. Agarwal, for being here as well. We have a few questions to kick off. I will just read them out, and either one of you are welcome to chime in. So the first one, why would you expect platelets to go up if RUNX1 is needed to make platelets and inflammation is generally associated with increased platelets?
Do you want me to take that?
Sure, yeah, I was giving you the first choice. Yes, please go ahead.
Yeah, it's a very good question, and I don't think we have all the answers. We're testing that actually. But my guess is what the mTOR inhibitor is doing, it's changing the differentiation of the cells. So it is suppressing the myeloid cells. So if we just take the FPD cells untreated, they make more myeloid cells and less megakaryocytes. When we treat with mTOR inhibitor, we are suppressing the myeloid cells. So overall, the composition of the blood or marrow changes, and that's why we are thinking it's rescuing the megakaryocytes. The inflammation is a tricky part, because what we also found that mTOR activation is increasing inflammation. So when we are treating with sirolimus, it's suppressing the inflammation. So there are lots of players in the bone marrow and blood contributes to inflammation. We are possibly inhibiting one arm, and overall impact is reduction of inflammation. But it's a really good question to be tested in the lab setting more.
And that's why you're here. Yeah. Great. Thank you. Okay, I will keep reading a few questions that I have here. But again, reminder to the audience, please feel free, regardless of whether you're patients or scientists or clinicians on the call, feel free to type in questions you have for Dr. DiNardo and Dr. Agarwal. So you mentioned some of the side effects, Dr. DiNardo. Can you speak to sort of what you expect to be the most common ones and the most concerning ones that might sort of lead you to consider pausing a patient on this trial?
Yeah, I mean, I think in terms of most common side effects, I think they're probably going to be fairly mild, given what we know about low dose sirolimus, and they tend to be maybe muscle aches, what we call myalgias, just kind of like the aches and pains, which could be headaches or more like joint or electrolyte abnormalities, things, which is why we want to be, cautious, and we're checking labs a bit more frequently than people probably would otherwise if they weren't on this therapy. The more rare but serious ones are also related to kind of the labs that we would be checking. In particular, kidney function, liver function, things like that. We want to make sure that is sustained. And so I don't anticipate any major challenges, but that is something that we're looking. We have had one patient initiate therapy so far, and she's been tolerating it pretty well. She has noticed a little bit of kind of what she described as more achiness after her normal workouts than she did before. So whether or not kind of that's related, it seems to be temporally related. It's mild, and she's doing fine otherwise. So that's kind of the experience we've had so far.
Great, thank you. It's good to know. Okay, and so I've actually spoken with a couple of patients who have lots of questions, and so I'm also drawing from that list. And so one patient is concerned about, and I guess you've just spoken a little bit to this, but one patient is really concerned about how this is going to affect her in her day-to-day life, and sort of has heard, sort of horror stories about some trials that have gone on a little longer maybe than needed. And so she was curious about sort of how receptive you are to to feedback. I could certainly answer what I think in that situation, but in terms of feedback to like when to stop and when to decide it's time to sort of unenroll from the trial.
I guess the most important thing for anyone to realize is that we would never force anyone to continue a therapy that they are not tolerating well, right? So of course we don't want people to have to fail therapy and come off without finishing it's a 6-month period, so it's not a super long time, but it's it's half a year. A year is a long time if you're not feeling well. So we certainly would never make people have to go through a miserable time in their life that is all just potential benefit and research learning, right? It's not as though we're treating a leukemia or other cancer or something where we really need to power through side effects because of XYZ, right? That's not this is a pilot study. So so all that to hopefully reassure that we would never make people stay uncomfortable. But I feel like the side effects with a low dose sirolimus study in most people are going to be very manageable. There's a lot of good supportive care adjuncts and medications if people feel mild nausea or mild joint pains, or there are things we can do to potentially help so that people can continue to feel well during the treatment course. But we would never force anyone.
Yeah, of course. And I guess relatedly, there are a lot of touch points, right? So I'm assuming those touch points you have are so that you can monitor and make sure everyone's doing well. But there, on the flip side, are people who, we have a small community. This is a rare disease. They're everywhere. So many have wondered about participating remotely, or are there options for some remote or travel to Houston? What do you say to patients then?
It's people want, I want both things too, right? I want to be able to see people and adequately follow and make sure any side effects are being managed and addressed, but yet also want to make it as convenient as possible for people. With this study, there are so many what we call correlative research samples being done, things that we are trying, labs that we are sending to Dr. Agarwal to really get to the bottom of how this is working and what inflammation markers are changing. That type of thing can't be done as a virtual visit because the samples have to be processed and shipped same day, and so it's not something that can be done virtually. So I'm happy to always, jump on a call or a virtual, call with patients like in between monthly visits, if there's something going on, and we can absolutely do virtual visits that way. But the monthly visits need to be in person because we, have those research samples being done.
Makes sense. Okay. And I'll just put forth that we've certainly been discussing with patients really on a case by case basis. Can the RUNX1 research program provide some support for travel? So happy to talk to patients as that arises. And one thing that did just recently come up with a patient is we realized that even for the first visit, right, the first sort of screening part, it's really a week-long-ish stay that they would need to plan for. Is that correct? Okay.
That is correct. Yeah.
Yeah. Okay. And then I think I had one more question. So so this is a 6-month trial, which certainly feels reasonable in some ways. And then also thinking about, if you're seeing a positive response for a patient, what are the next steps? Is there an option to sort of continue on the medication, or is that not how it works?
It's not officially how it works. This study does have an endpoint. And so officially we would be coming, off this clinical trial, which would be ending. If someone was, I hesitate to say anything that's going to be recorded. So I don't know exactly. If someone is feeling dramatically better and or something about their lab work or something is significantly better, it's hard to say we should stop. If there's so I'm certainly open to those discussions and trying to figure out whether we should be continuing this in an off protocol, kind of turning it into like a patient standard of care. So those are absolutely kind of discussions that could be had.
Yeah. And I guess we could speak more formally to maybe, okay, so if that's not an option, what happens next after this phase of the trial, or this phase? It's phase 1B or phase phase 1?
It's a pilot study. It's really officially kind of, I guess, a phase 2. It's not quite big enough to be a phase 2 because the statistics aren't built for it. But we know the drug, we know the dose, so it's not like we're a phase 1 investigational brand new agent. So pilot is the best way to describe it. Sorry, what was the question?
Oh, sorry. So what would be the next step? So at the end of the 6 months, assuming you can recruit, it's 4 to 5 patients you're aiming for, right? What happens next?
Well, it kind of depends on what we see. And if we see promising things, as I hope we do, then a pilot study can turn into a larger, more confirmatory study where we have the kind of true like built-in statistics to try to say like, this is really, changing things in a positive way for individuals with germline RUNX1. So we could be, getting kind of a larger grant support to expand this study and do it in a more definitive way.
So those are the only patient questions I've seen so far. If I just want to put a plug out for, we've said we'll prioritize patient questions, but if any of the scientists or clinicians on the call want to also chime in, please do feel free, because we have Dr. DiNardo and Agarwal here. But also I'll mention that in the chat, Catherine Pelton, our communications manager, has dropped in a link to a 1-page summary that RUNX1 Research Program has put together based on materials available. And on that page is the direct link to the clinical trials.gov protocol entry. I'll give it a few more minutes for Q&A, but I don't want to keep you all on if I'll let you recover half your day with just my questions. But I've just had so many patient questions, and we had our patient meeting in Houston last month, which was really great. It was fun to see patients there and seeing them ask questions and see the first patient on the protocol really excited to be there and share that she was there participating. I'm watching for questions. I had another question that was related to what I've heard others ask. I mean, this is such a hard question. A lot of, we have patients sort of seeing several clinical trials coming on board. At once, there's the imatinib trial that came on board out of the NIH, then yours, and then there's a stem cell harvesting trial that is available at MD Anderson as well. And then there's some we know that are in the works. And I think one of the sort of curiosities from patients is how do they sort of evaluate which one is best for them? This is a really hard question for you. So if you're just like, I can't answer that. I'm curious if you have any guidance for the average patient in terms of thinking about these different opportunities. Imatinib is focused on, I believe, increasing RUNX1 activity. That's different from Sirolimus, obviously. Any thoughts?
No, there are really kind of three main studies open right now. One of them, the one that we haven't mentioned really is the one that's being run through the transplant department here. That is kind of essentially a pheresis storing of stem cells. So that could be done irrespective of these studies. So if that's something that sounds of interest to you, kind of getting stem cells stored, and who knows in the future what sort of kind of amazing cell therapy directed approaches we can harness that. I think it's a pretty cool trial that that procedure that is available. And so that you wouldn't be doing both at the exact same time, but a patient could do a therapeutic trial as well as the transplant trial. In terms of Sirolimus versus imatinib, I mean, I don't know. I think it really kind of just depends on maybe where you live in the country and which is closer and more convenient in terms of logistical things, because I think the data behind both are pretty solid. Both therapies should be well tolerated, and they're both FDA approved for different indications, and we know a lot about kind of safety. And so I wouldn't be concerned that one's going to be particularly more effective or more toxic or things of that sort. So.
Sorry, I know that's a hard question to answer. It's just sort of what we're trying to work through with our patient community. And honestly, that kind of aligns with what we've said, like just pros and cons of where you are. And, there's physically, are you already traveling to the NIH for the natural history study, et cetera? Yeah.
Exactly.
Yeah. Okay. Someone did ask how many people can join this study?
Six as of now, unless we expand.
Okay.
Yeah.
Okay. And all 18 and older, is that right? Adults?
That's correct. Yes, you have to be 18 or older.
Okay, sounds good. Okay, well, I'm not seeing a ton of questions come in, so I would encourage everyone to take a copy of that summary. And then I guess final question would be, and then Catherine just hopped in with the survey evaluation feedback for this webinar. So please take that so we can continue improving these webinar opportunities. But last question would be, who would you suggest patients or clinicians reach out to with questions or inquiries about enrollment? Is that you, Dr. DiNardo, or your team?
It easily could be me. Because I know I'm on, my email is kind of in your group and you provide it, but Jill Mullen is also someone that I think you're in contact with. She's the research kind of nurse manager who's running this trial that is super, great to get a hold of and can help, follow up. And so she would be another great contact that Amanda, you could, provide if people wanted to reach out and just ask a couple questions and, at least on a preliminary basis, do I look like I could be eligible, that type of thing.
Okay, great. Yeah, happy to share that. We'll have an email that goes out with the recording and the survey and the summary sheet as well. And so we'll share Jill's email address because I do have that.
That's great.
All right. Well, thank you for your time. Really excited to hear the first patient's doing well, and we will keep, spreading the word we'll keep in touch. Thank you, everyone.
Take care, guys.
Take care.
Thank
Bye.
you. Bye.
Thanks.